Welcome everyone to today's webinar, The Role of Hospitals in Optimizing Postpartum Mental Health. Thank you so much for joining us today. My name is Aisha Zeda. I'm a Senior Program Manager at the AHA, and this webinar is co-hosted by our partners at the Policy Center for Maternal Mental Health. Joy Burkhardt, who is the CEO and founder, is also on. And Joy, would you like to say a few words to our attendees today?
Sure. Good morning or good afternoon. It's a pleasure to be with all of you joining us live and also watching today's recording. Just a little bit about the Policy Center for Maternal Mental Health. Our mission is to close gaps in maternal mental health care. And as all of us likely know on this webinar today, we have a significant shortage of treatments and providers to support the postpartum period and the full perinatal period. And so we're thrilled today to recognize the role of hospitals. We call hospitals the hub of birth here in the United States, really can play a significant role in closing those treatment shortage gaps, and thrilled to have the speakers joining us today. I will turn it back to you, Aisha, to introduce our speakers. Thank you.
Yeah, thank you so much, Joy. And as many of you already know who are on, that the postpartum period is a dangerous time for new moms. 63% of pregnancy-related deaths occur in that time. So it's really important that we take that into consideration when we are implementing programs for new moms and for postpartum moms. Postpartum depression and anxiety are the most common complications of birth, and maternal suicide and overdose are the leading causes of pregnancy-related deaths. So today we're joined by healthcare leaders who are dedicated in creating and implementing programs, tools, and services to really improve those postpartum maternal mental health outcomes. Today we have Cherie Barker Johnson, who is Executive Vice President and Chief Nursing Officer at Women's Hospital in Baton Rouge. We also have Dr. Sarah Nagel-Yang, who is the Vice Chair for Quality and the Deputy Executive Director for the Colorado Center for Women's Behavioral Health. She is also the Associate Professor of Psychiatry at the University of Colorado School of Medicine. And then we have Jocelyn Kelleher, who is the Clinical Director for the University of Colorado School of Medicine, Department of Psychiatry, and then Melissa Katowski, who is the Program Director at the University of Colorado Hospital. Thank you so much for joining today. We really appreciate your insights that we'll be hearing from all of you and the great work that you're doing. Before I kind of move into the panel discussion, I want to share that this webinar is being recorded and it will be posted on our AHA YouTube channel, and then also will be shared with all the participants today. We will have time for Q&A towards the end of the webinar, so please chat in your responses, and we will take a note of them as we're moving along. We will also share a set of resources towards the end of the webinar as well. So let's kind of move into learning more about all the great work that our hospitals are doing here. So to help our listeners understand the settings that you're coming from, can you talk a little bit about your organization, the demographics of the maternal health population, and how is perinatal and postpartum mental health showing up in your community? Cherie, I'll have you start.
Oh, thank you very much. And it's a pleasure to be here with all of y'all today. A little bit about Women's Hospital. We are a specialty woman and infants hospital located in Baton Rouge, Louisiana. We do about 8,000 deliveries a year. We have the biggest NICU in the state, so we do about 1,200 admissions into our NICU. We also do a lot of female surgery, so we only admit women and we only take care of babies. Really, we have more babies in our hospital every single day than we do adults. We do about 10,000 surgeries a year, nearly 40,000 mammographies. So kind of just a high volume in terms of women and infant services. We have had an outcry really from our staff who take care of women and our medical staff who take care of women for a number of years now to really provide more support for women with perinatal mood and anxiety disorders, depression, just for women in general. So that really has amped up in the last 5 years. So we did start the journey of hiring psychiatrists for the outpatient setting to kind of assist our OBGYNs. And as things continue to grow, we really saw the need to have more spaces for pregnant and postpartum women to be specifically. And then we started receiving feedback, because as you start to refer off to psychiatrists and they need inpatient care, we get feedback from our medical staff about our women really being in facilities that are co-ed, where they don't feel safe, where they cannot see their baby, and really where their pregnancy needs aren't really being met, or lactation support. I had a patient transfer to me that had a breast abscess because she didn't have access to being able to pump, and she was breastfeeding. Just all of those important things, which really kind of have led us here. I also sit on the Perinatal Associated Maternal Mortality Review Committee for our state of Louisiana, and really started identifying if we could have been here at this point for this mom, we would have prevented the outcome. And it's really kind of flipping the mindset and really having some of those conversations with the members of the committee. So a lot of times we think, well, there wasn't mental health available. I don't know how this death could have been prevented. And we really need to flip the script and say, yes, that it's really a systematic problem, that we've got to have mental health help available, and we can prevent some of these maternal deaths. So that's kind of how it's showing up in our community. It's really coming from the providers who take care of women.
Thank you so much, Sherry. Sarah, do you want to talk about from the Colorado's perspective?
Yeah, thank you. And Melissa and Jessalyn, please jump in if I miss anything really important. So our program is based in Aurora, Colorado, so just outside of Denver. We are in a large urban academic teaching medical center. I believe that we have about 4,000 deliveries a year in our main campus, and then we have kind of a whole health system that really spans the state. And then for, particularly for individuals that are experiencing higher risk pregnancies or have more medical complexity, we actually care for people in bordering states as well. So we really sort of have a pretty wide service area, I would say. And the services that we're going to talk about today exist within our women's behavioral health and wellness programs, which is through the Department of Psychiatry. This program was established in 2018, so I would say still relatively new, but still, very active and growing as we'll talk through. We have about 20 faculty members on our team, and we really span a lot of settings. We try to really I think the growth of our program has been informed on the goal of increasing access to care and across the spectrum of perinatal care experiences and needs, and also across the spectrum of mental health acuity. And so we have our faculty here in our outpatient setting where I'm sitting today. We have faculty who are in inpatient, OB, and NICU settings, as Melissa and Jessalyn will share with us. We have faculty who are integrated into outpatient OB/GYN spaces as well, and even broader than that. And so we're kind of like a group of people who just are all over the place and in the places where perinatal people are. And I would echo, so I also serve on our state maternal mortality review committee. So I would love to hear kind of what approach is happening in the conversations that are happening in other states as well. We're having similar conversations in Colorado, I can tell you. Just like many states, suicide and unintentional overdose are leading causes of maternal mortality in our state. And there's a, really strong and growing, I think, awareness of the need to effectively address those concerns. Certainly, there are a lot of, there's been so much progress in terms of guidelines and recommendations. And I think that now figuring out the logistics of how to best integrate this care into our OB-GYN settings and have access to specialty care when that's really what's needed as well. And that's been part of what our program has been trying to address.
Great, wonderful. Thank you so much for sharing that background of the community that you serve. Cherie, in September of this year, you launched the 10-bed perinatal mental health unit. Congratulations on that. Can you walk our listeners into what was the impetus of the unit? How was that implemented? What kind of stakeholders were needed to kind of launch that, and who are, is part of the staff right now at the unit?
Well, as I described, it's a big leap to move into inpatient behavioral health in our setting, right? I deliver babies. We take care of women and infants. We have a really big NICU. We are not associated with a system. We don't have behavioral health services. We kind of have to, put on our bootstraps and really kind of dig in. The biggest driver was really two things, actually three. It was board supported, right? So we got stakeholder support from the board, but it was really what we were seeing in our own hospital and worried about the care that women, particularly pregnant women, postpartum breastfeeding women, were receiving. And the number of patients that our medical staff were having to send out of our community to be able to receive like intensive inpatient care. And that really was a huge driver. It was really kind of partnering with the organization saying, we've got to be able to better take care of pregnant women and really help address some of the maternal mortality that we're seeing. Knowing that this is a service that's not going to cover its cost. And so that was a lot of discussion, and how do we make this work, and how are we going to move forward with this? So we have the fortune to have a shelled space. So we had space that existed. So it's not like we had we still had to construct inside the space, but that did help kind of reduce some of the cost. We did make the choice of making every single room a private room, so we could do maybe counseling and individual therapy in that area to kind of save in some space. But there were a few things that were really important to us. We wanted our group room settings. We have two separate group rooms, one for more acute patients, one for less acute patients. And we really wanted that to be in a great place where if we did have the family visiting, there could be a space with windows and a space that was really inviting for our families as they visited. We wanted to have the ability for people to have a space where they can decompress if they need to, or even pump or feed their baby when we have baby visitation. So those were some of kind of our key drivers with that. And then we also wanted to have a little bit of outdoor space. We did model a lot of our program off of the program at UNC, University of North Carolina at Chapel Hill. Made a couple of visits. Great friends. They are great people, and they have a great program. Their medical director came and talked a couple of times to our medical staff and came to our medical staff at board retreat, just talking about how they have their unit. We went up and took a look at them. We spoke with Northwell up in Queens, UC Davis, which is really kind of trying to garner the best of everything that the other folks were doing to kind of build our program. How we kind of function is, we've got psychiatrists there every single day. Not being in behavioral health space, I just assumed other behavioral health inpatient settings, you might see a psychiatrist every day. And in our state, I'm not certain about other states, that's not exactly true. So I was shocked by that, because in my world, you get seen by a doctor every single day if you're in the hospital. So we had some guiding principles of how we really wanted to build our program in such a way that our women got the care that we really felt like they need.
That's wonderful, Sherry. I love that you got the board support. Yeah, I think that's really important. Sorry, did you want to add anything else?
The patient stories, I mean, all I had to do is go to the board and say, these are the things that I'm seeing. And when we started looking at this, I had staff that came to me and said, I had this issue, or I went to a state, facility. I was really struggling, and I had to get out of there because I felt unsafe. And they went to UNC, or and they had the resources to be able to do that. And so, there's no secret. Louisiana is, ranked #1 in food, right? And a good time, and ranked last in everything else, healthcare outcomes, name it, obesity, cancer, poverty, those kinds of things. So we knew that we wanted to be able to have a place where those folks who don't have the resources have an ability to have inpatient care.
That's wonderful. Let's kind of hear from our University of Colorado team. I know you have both inpatient and outpatient programs for maternal mental health. So can you, Melissa and Jocelyn, can you each kind of walk us through what those are? What are you seeing as sort of like your most successful ones? And how are you implementing that work?
Yeah, Sarah, would you want to talk about outpatient, and then Justin and I can talk about inpatient, or vice versa? Would that be helpful?
Yeah, maybe you guys can start with the inpatient side, then I'll talk.
Okay, I'll go first, I guess. So I work as the director of the Perinatal Behavioral Health Pathways program, which is an integrated behavioral health program that works on the mother-baby unit on our campus. And so I predominantly serve the postpartum population, with a little bit of service sometimes to some of our folks who are admitted on the antepartum service or admitted during pregnancy. Our staffing is a little bit varied. So most of it is about part-time coverage of myself, who's the psychologist who's there, usually about like 3 days a week or so. And then we also have part-time coverage from a reproductive psychiatrist as well for some of our folks who have medication management needs. Anybody who's admitted to our service can be consulted. We can be consulted on them and help assess. We do a lot of kind of therapy, supportive therapy responses, a lot of cognitive behavioral interventions. We do some health behavior interventions for some of our folks who have a lot of medical complexity. And then, of course, our behavioral health team is addressing sort of the standard perinatal mood and anxiety concerns, some more serious mental health conditions, postpartum psychosis, those types of things, bipolar disorder. And then also we have a really large focus on people who have had traumatic deliveries, challenging deliveries, medically complex pregnancies, and or postpartum complications. And then we also see our folks who have second and third trimester fetal losses or terminations. And so we serve those populations as well. And so all of that is typically within the admission that is typically a postpartum admission, so really 1 to 4 days. So we sort of have this kind of quick turnaround interaction with patients while they're admitted briefly on our unit.
And then I can speak a little bit to the Connections program. Apparently there's some kind of feedback when I talk, so I apologize in advance. I'll try to be efficient. So I am the clinical director for the Connections program for high-risk infants and families. We consider ourselves as conception to kindergarten care for families who are expecting or who have a medically complex infant or young child. And so we can intervene again during pregnancy if, say, there's a fetal diagnosis that is known at that point. But most often in the postpartum period. We have 3 psychologists, myself included, that between us, we do about 1.5 FTE in the NICU per week. So we are embedded into our local University of Colorado Hospital NICU, which is a level 3 trauma center. As Dr. Nagliang mentioned kind of earlier, our campus has become kind of the place to go in the region for people with high-risk pregnancies, and especially those expecting a very early or very complex delivery for their baby. Our team now is resuscitating babies as young as 22 weeks in certain situations. And so we have the unbelievable opportunity to kind of walk alongside them through the weeks or months, most often months in the NICU, providing health behavior services, family support and coping, staff interventions, and staff support. We do universal screening for all birthing parents. And then we can do a lot of, I think our program is what I like to think of is a good example of kind of the combination of inpatient and outpatient care. And so we have our inpatient arm in the NICU, and then we also have our outpatient arm where we can do extended therapy for families, either individually or for couples. We have a group for moms who have either a NICU baby currently or a NICU graduate, and then groups for fetal and neonatal loss. And so that's a little bit about what we do from the Connections side.
Thank you, Melissa and Jocelyn. And then Sarah, do you want to talk about the inpatient side?
Yes. So, so I'm going to talk, I think, about our outpatient program. And as you heard from Jocelyn, there's a lot of fluidity, right? And so patients obviously go in between these different locations. And one of the, I think, really valuable parts about our inpatient services is identifying individuals who maybe haven't been engaged in prenatal care before their delivery and are going into this very high risk period. They may have additional risk factors for perinatal mood or anxiety disorders, and or individuals whose risk has really changed due to their delivery experience. And so Melissa was kind of highlighting, it's a really short, hospital mission. And I think sometimes people can lose sight of what a big opportunity it is, even with it being a short stay for most individuals. And then our outpatient program, again, we're on one campus, so we're just like in a building, a walking distance away. We have some traditional outpatient kind of offerings like reproductive psychiatry, individual therapy. We have a number of group therapy options. We've really focused on group therapy as a primary, kind of center of our model of care. Number one, because there's so much isolation that people are experiencing that we just really think it's a really powerful intervention. And it's one that allows us to maintain access, because we do have a high volume of referrals, and we want to be innovative in terms of how we meet the need. I know some of the materials that you're going to share with the attendees, I did list kind of the groups that are happening in our outpatient space if people are more interested in hearing about that. And then within our outpatient space, this past March, we launched what we call the Healthy Expectations Perinatal Mental Health Intensive Outpatient Program. So this is, just like it sounds, a more intensive program that's designed to kind of provide care for individuals who would benefit from more than what is typically offered in kind of traditional outpatient therapy and potentially medication management. So typically we're thinking about individuals who have moderate to severe perinatal mood and anxiety disorders or other perinatal mental health conditions. And we really, aim to help people get a higher dose of treatment so that they can get better sooner, and also lay this foundation for kind of their healing going forward into the future. The IOP is 3 days a week for 3 hours a day, so it's 9 hours a week. The primary modality is group therapy, and we offer individual therapy and medication management based on need. And then each of those days, so it's Monday, Wednesday, Friday morning for us, there are 3 groups. So there's a lot of threes in this kind of explanation, but the first group is really based on acceptance and commitment therapy. And so they're really focusing on building skills to manage mental health symptoms and coping. The second group is based on Circle of Security parenting, which is an evidence-based parenting program, really thinking about dyadic work and really focusing on developing a secure attachment. And then the third group is a wellness group. So we do various topics, like, for example, I think this week we're talking about developing routines for you and your baby. We also do a lot of dyadic play during that time. We have somebody come and do trauma-informed yoga. So it kind of varies week to week, but the third group, and then that's kind of right before the wrap up, people are doing something to kind of, to reground themselves and also to focus on their overall wellness. And so in the IOP, the people come in and out based on their need, but it's an 8-week curriculum. So what we recommend for people is, yes, that 9 hours a week for 8 weeks, and then we can transition again to some of our other programs, our community programs, if that would be a better fit for any patient.
That's great. I love that you have the both inpatient and outpatient side covered and have wraparound services around those units. My question to all of you is, given the role of obstetric providers and has been emphasized recently around routine screening for maternal mental health disorders, how are you engaging OBGYNs and midwives to and kind of inform them, educate them about the programs and treatment programs that you have in place? How has that communication been? Sarah, do you want to start?
Yeah, I could go, if that's okay. And then, so I would say this has been a big part of kind of our strategy. Again, not only in sort of making sure that providers in our communities know about our services, but that they get support for implementing treatment within their own settings as well. So, definitely our integrated care teams are part of, of the healthcare teams of the clinics that they're in. And that, offers a lot of support and also just treatment options and also awareness, I think, about our broader services. We also have partnered with it's called Colorado Echo. So Echo is a model that's really based on kind of, again, extending kind of the role of traditionally primary care clinicians, but it has been implemented in lots of other types of settings as well, and is virtually based and really focused on especially providers in rural areas. So we've done 4 iterations. Actually, we just finished our 5th cohort of our perinatal mental health echo series. And so that's really a training kind of experience for people who participate. And then this last year, we also are one of the other members of our team who are on the call today, are leading kind of the implementation of a HRSA-funded statewide perinatal mental health access program. So again, partnering with frontline providers, and offering referral resources and other kinds of connections, either to our programs or to others. And then we've done a lot of marketing, I'll say, to providers. We just started, actually in December, we'll have our first newsletter go out, just people who we know who are referring to us are on our list of people who may want to refer to us, to kind of keep people updated with what's going on in our programs. We've started putting information on the TVs and the OB waiting areas about our programs, developing more flyers and website and some of the more traditional marketing strategies as well.
That's great. Cherie, do you have any thoughts?
Yeah, so similarly, it's kind of getting out to the obstetricians and our providers' offices. So I think that One of the big fears that a physician has is I screen and I don't know what to do. Right. I mean, that's their biggest thing. So we couldn't go to them and say screen without providing them some support to be able to do that. So we kind of have an access team that when somebody screens positive, we go to their office and we take it from there. So we have a team of social workers that come in. They're guided by our psychiatrists in terms of any assessments that might be needed, a further assessment if they need to go to the emergency room, that type of thing. So we kind of have, what we call our access team, kind of go to where the office is and take care of it. Now we're fortunate, our physicians are all in our physician office building right next to us. So it's not the proximity, it makes it less complex. But then we can also get them referred off to where they kind of need to go. And the same goes with substance misuse, kind of similarly, and get them linked to resources.
Great. I know once a mom has her baby, she goes back into the community, back into her home. So it's really important that our, perinatal mental health programs are sort of rooted in community. How are you engaging the community in this work? Sherry, I know that you have the GRACE program. Can you talk a little bit about that?
Yeah, I'd be happy to. It's a program that's my pride and joy. I'm gonna kind of take us on a patient story because I'm a nurse and I believe in patient stories, and that's how I get buy-in with everything I do. We had a patient, her name is Molly, several years ago, who dropped out of prenatal care, arrives on our doors, has a healthy baby boy. However, because of her ongoing heroin use, she is in septicemia, septic shock, not doing well at all. We sent her to a tertiary center where she underwent a emergency open heart surgery to do a valve replacement, and she died on the table. That spoke to me because as we did our due diligence in terms of a root cause analysis, is there anything we could do? I really believe in my heart that maternal mortality could have been prevented had she not dropped out of prenatal care. So I marched around as much as I could and spoke with different people to give me money to start up my visionary program, which was to have a social worker and a nurse link with those with substance misuse and get them referred to community resources. Because again, I'm a women's and infants freestanding hospital, but I know who my community is and I can get them linked to resources really with a whole program that is embedded with risk reduction strategies, safety, and getting into prenatal care and staying in prenatal care to kind of save her life. We take all comers. I see a question in the chat, like is Medicaid accepted? And yeah, but this grant that I originally got from United Foundation kind of allowed us to develop some of the structure and really do a proof of concept. So the patients that we have had that are in our GRACE program, their babies are 1.3 pounds heavier at delivery than those who are not in our program. They deliver 3 weeks later in gestation than those babies that are not, or those women that are not in our program. And then 85% of our moms stay in treatment programs 1 year after delivery. So that's been some of our metrics with that. So it took me a number of years to get the payers convinced, and so I do have contracts with all the different payers. That was pretty tough, but the data is the data. So to me, this is a big success story about you don't have to provide the service yourself, but you got to have somebody to help navigate that patient through. And there's no other time to be more motivated to really seek out help and get treatment than that. And so as we've kind of talked about the success of our program, it really helped our providers to screen more because they knew we're gonna help you. We're gonna help you. And I think, again, I'm gonna reiterate it. We've got to create some structure for these providers to screen better, so they have support to be able to manage those patients. Obviously, I'm pretty proud of that program.
Oh, it's wonderful. Thank you for sharing that patient story as well. Really appreciate that. From the Colorado team, how are you engaging with community partners in the work that you do in either the inpatient or the outpatient side?
Yeah, I can take this one. I think it's so incredibly important both for inpatient and outpatient to invest with or to engage with the community. We are, I would say, pretty fortunate in Colorado to have a lot of services that support moms, babies, and families. I think the challenge, or one challenge in such a big state, is that it's often that different programs or opportunities don't know what else is out there, right? And so that's why I think entities like our state partners, so the Colorado Department of Public Health and Environment, CDPHE, trying to make sure I don't mess up these acronyms, or the Colorado Perinatal Care Quality Collaborative, that's a very hard one for me to say, CPCQC, like having those state partners so we can see what's going on in Northern Colorado, what's going on the Western Slope, things like that has been really helpful, and just building those connections so that it's not that we can only serve people in the Metro Denver area. That's not aligned with our mission and vision. We want to serve anyone that needs our services. And so I think those statewide partners are incredibly important. And I will say on the Connections program, we are in the process. We got funding and a grant approval to set up a community advisory network to see, again, for our kind of high risk NICU population, what is out there? What do we maybe not know about? What are the gaps that we're missing in our communities? And we're really working to engage both folks with lived experience, so NICU families, people like that, as well as people with professional experiences. So nurses, docs, doulas, lactation consultants, early intervention specialists, things like that, to get a broad range of voices to see, like, again, what is out there already in the community? How can we amplify what's going on? How can we connect to what's going on? And then what are the gaps and how do we start to fill those?
I'll just add too, I think kind of from the inpatient side of things, thinking about Jocelyn did a wonderful job talking about kind of some of the sort of broad reaching programs kind of statewide, right? And then also thinking about some of the things that we can do for the folks that come to our hospital locally when they're admitted. And I think it's just really important, kind of to Cherie's point earlier of like, it's one thing if you identify a problem, it's another thing if you can't get someone connected to services. And so sort of thinking about the wide variety of types of support that patients might benefit from. And so oftentimes that can and should be sort of what you might think about as more traditional mental health, so sort of psychotherapy, medication management, but so often, sort of to Jocelyn's point earlier, there are lots of other community supports and resources that might be really beneficial to decrease isolation, enhance sort of connection, validate really normative experiences that might be really challenging for families. And so there are some local and community organizations that do some of those things. There's like a doula program, for example, that helps some of our folks with substance use and can help with kind of home visits. We have some other community-based parenting interventions and things like that we can connect folks to if the type of support that might be most beneficial for them isn't necessarily a one-on-one individual therapy type approach. And so I think that's really important too, and often I think can enhance engagement when people feel like they have something well matched to what their need is and not just something we might think about as traditional mental health.
Yeah, and just to piggyback on that too, I think that speaks to, right, like the diverse population that we're seeing and the diverse needs is that there is no kind of one size fits all treatment. And we as, say psychologists in my case, need to understand that and need to be humble about that. Not everyone needs or wants to see me, and that is very okay. What can I help connect you to? that does make more sense for you and your family.
Yeah. I know we have a couple of questions coming in through the chat, so I just have one or two more questions regarding outcomes and learnings. Cherie, with your unit just starting just about 2 months ago, I'm sure there's a few lessons learned in this process. Can you share some of what you're seeing in regards to learnings, in regards to outcomes? And then for the Colorado team, I would love to ask, what are some of your sort of standout programs and what are some of those outcomes? So Sherry, can you start us off?
Sure. So I think I might have mentioned before, we didn't do, our program is really young, and Dr. Nagel Yang talked about how they've marketed. We didn't market, we just marketed locally into our own community. So this September 3rd is when we opened up our unit. So through mid-October, end of October, close to the end of October, we've had a total of 43 inpatient admissions. So we were kind of surprised by that. And so that's pretty local. We've gotten a couple of patients that came out of a couple of counties in Texas. Our length of stay is really averaging about 3 to 5 days. So we were surprised with that. When we did the modeling, we really looked at what are we seeing now, and that might be what we see in the unit. We did go back and kind of look at the length of stay of women that went to other facilities, and they were considerably longer. So we're really surprised that we're really getting them stable and back out to the community as quickly as possible. It's about a 50-50 mix between pregnant women and postpartum women. Another surprise for us. We really thought we might see more women who have suffered loss or postpartum, but we're actually seeing more women pregnant, twins, high-risk pregnancies. I did fail to mention earlier, we have a very large group of maternal fetal medicines physicians. There's 6 of them, and they do travel throughout the state. And so we are a referral center. So we're getting more high-risk pregnancies than what we really anticipated, which is good. We're in a great spot for them because we can comfortably take care of twins and women with higher blood pressure, things like that. So that's pretty great. We just kind of a breakdown of where we're seeing our patients kind of come from. The majority is coming from the offices. So 50% is coming from our clinical providers, or they might be seeing a mental health provider. It's not even our own employed mental health providers. It could be a community health provider, and they've reached out to us. About 29% are transfers from other hospitals. So we were kind of surprised by that as well. And then 14% come from like a non-healthcare facility, so not an office, a clinic. And about 7% are coming from a distinct unit or a different hospital, like ED to ED kind of transfer. So that's kind of some of our statistics. We are shocked that I did model this to see about 75% Medicaid patients, because that's what we were seeing. And we're less than that. We've got some private insurers patients. So I think folks are really, really looking for access. We've seen patients from 13 different parishes across. We have parishes and not counties in Louisiana. And from our surroundings, community, most of our patients who are pregnant are in their 3rd trimester. So that's been a surprise for us as well. The breakdown of our patients, we've had a small amount of psychosis, but we were actually kind of, from what we were seeing, we didn't realize we were going to get that large of a volume of psychosis kind of coming in, because that's not what we saw in our own data. So we were kind of surprised with that. Most of the diagnosis surround mental health conditions like bipolar disorder, lots of depression, obviously, and lots of trauma. So what we had to really kind of really address in our group therapies is really adding trauma into those group therapies. So that's kind of a little bit of breakdown. A lot of women pumping, surprised by that. We've kind of had to get more supplies related to lactating women, so I'm happy about that. So our lactation consultants go in there, and our infant visitation is really going well. So we don't allow the babies to spend the night because we really want to protect sleep. That's really important in terms of healing. But really, really happy to see those families bring those babies in, and that's been very, very, very positive. So just kind of, we're real young, so talk to me in a year. I don't know what it'll look like in a year. I have no idea what will look like in a year. Mental health is a tough job. And I have to tell you that the nurses that are working in there feel renewed and rewarded because they feel like they're really making a difference.
Yeah.
Anything that I'm missing? Anything that I'm missing that I need to talk about?
No, okay. It's been open for a short time, but you've seen some great achievements. So congratulations. For the Colorado team, can you guys talk a little bit about some of the successes on your end?
Absolutely. If I can jump in first to talk about connections, if that's okay. So the Connections program has been in existence since fiscal year 20, and we are a rapidly growing team. But when we started in fiscal year 20, 32% of our encounters overall were with Medicaid beneficiaries. That includes inpatient, outpatient, and developmental testing. And by fiscal year 24, 56% of our encounters have been with Medicaid beneficiaries. And so we're really, really proud of the increase in that number, again, as we think about access to care. Again, Colorado is a state that does have a lot of behavioral health options, but not always ones that can be accessible by people who are insured by Medicaid. And so that's an area that we focus pretty heavily on. And then also in this last fiscal year, 62% of the counties where our patients reside are considered rural or frontier, which also is a big deal in Colorado. I'm from Massachusetts, so Colorado is a ginormous state to me. And so it's really, the fact that you can drive 6 hours in one direction and still be in Colorado is kind of wild. But through, telehealth and all of the support that we have from the university side, the hospital side, and insurance and payer side to continue telehealth care, we've been able to, again, serve people from all over the state of Colorado. And again, we're in the position where families come to us and to our NICU from all over the state. And so it's really nice that we are then able to have continued continuity when baby gets to go home. And then we thought a lot on our team about how to really, account for patient satisfaction. And so we did a survey recently, and 100% of our patients across inpatient and outpatient settings reported being satisfied with their services. The really interesting part that we also thought a lot about is that for, again, parents of high-risk infants, you're not necessarily going to see, oh, their scores are decreasing on this depression measure or this anxiety measure, because it really waxes and wanes with how baby's doing. And, we've got parents who are preparing for the next surgery and things like that. So those kind of traditional models of like, oh, people are doing better because their scores are going down doesn't really fit our population. And so instead, we asked kind of post-pre questions about like key metrics. And so things like increased coping ability, like ability to cope with stressors, or increase connectedness and decrease in isolation, and then connection and attachment with baby. And we saw increases in all of those key areas for people who participate in our programming. And so that's how we feel like, okay, we're being effective here in the work that we're doing, because it's not represented in traditional scores. So again, we're really excited about seeing that, like, okay, the work that we're doing is having an impact, and we're continuing to see how can that impact not just disproportionately be not just have an impact on those in Metro Denver with access to a lot of resources. So we're very proud of that.
Thank you so much for sharing all the great work that you're doing, all the outcomes, I can definitely see the passion that all of you have around this, and which is really important when you're in this space. Thank you so much, Cherie, Melissa, Jocelyn, Dr. Nagley, for joining us today and sharing all the great work that you're doing. There's a lot of feedback in the chat about learning from all of you. So if anyone is interested in connecting with any of our speakers, please feel free to email me. I'll drop in my email in the chat. And then my colleague Julia also shared an evaluation form. So please send us your feedback on how you liked our webinar. And then she'll also drop in a set of resources for all of you to take back and look and kind of dig deep into the programs at University of Colorado and Women's Hospital, and some resources from the AHA and from the Policy Center as well. So again, thank you so much for joining, and we hope that we can kind of bring these kind of webinars and programmings to you again next year.